So it's a pleasure for me to be here with you today, and I'd like to thank Dysautonomia International and Lauren Stiles in particular for the invitation and the opportunity to speak with you about Ehlers-Danlos syndrome today. I have no conflicts to disclose about the information I'm presenting. What I'd like to do is just kind of review where we are in terms of the diagnosis of Ehlers-Danlos syndrome, because we've had a real sea change over the last 2 years in terms of the way we think about the diagnosis for this condition. Really, I should have titled this slide the Ehlers-Danlos syndromes, because we have now 13 different recognized in the 2017 classification. This is a heterogeneous disorder of connective tissue, and it's characterized primarily by joint hypermobility, skin hyperextensibility, and tissue fragility. And these three features vary considerably between the different types of Ehlers-Danlos syndromes. So most of the forms result from mutations in genes encoding collagen, which is the predominant protein of connective tissue, or in the enzymes that process collagen or other connective tissue elements. Now, Laura will tell you a little bit more about how we came to this 2017 international classification. But if you want more information than I'm able to give you today because of time constraints, I suggest you go to the Ehlers-Danlos Society website, which is at ehlers-danlos.com. And there's a link here to the paper describing this 2017 Ehlers-Danlos classification. This classification arose from an international symposium that took place in 2016 in New York, and it was organized by the Ehlers-Danlos Society and EDS UK, and there were almost 100 scientists, and 18 papers resulted from that deliberation. There were committees about each of the different types of Ehlers-Danlos syndrome and working groups on each of the different comorbidities. And then each of those committees produced the papers that were published in the American Journal of Medical Genetics in March of this year. And there are links to each of those papers at the Ehlers-Danlos Society website now. So this is the front page of the American Journal of Medical Genetics, Part C. Each one of the papers in this volume discusses one of the types of Ehlers-Danlos syndrome, the classification of Ehlers-Danlos syndrome, and the comorbidities that we associate with the different types of EDS. So this table gives you the list of the classification of EDS types as of this 2017 nosology, and the major types, which I'll discuss with you today, are the classical type, the vascular type, and the hypermobile type. These are far and away the most common of the forms of Ehlers-Danlos syndrome, and the rest of them are really much, much rarer, probably by at least an order of magnitude fewer individuals affected thereby. So the classical type of EDS, in the 2017 criteria, the major criteria are the skin hyperextensibility and atrophic scarring and joint hypermobility. And the skin, the stretchy skin is really very, very typical of the classical type of Ehlers-Danlos syndrome. This degree of stretchiness is something that we really don't see in any of the other types. And also, very typically, the skin fragility results in very, very kind of characteristic scarring on the shins of affected people with the classical type of Ehlers-Danlos syndrome. So when we see this kind of scarring on the shins and this degree of skin hyperextensibility, we really tend to think of the classical type of EDS. Now, the Beighton score is relevant to all of the different types of Ehlers-Danlos syndrome because it is the measurement that we use to assess for joint hypermobility. And so I'll just go through this diagram, which comes from EDS UK, which describes how we assess the Beighton score for a measurement of joint hypermobility. You see here, this woman is bending over and putting her palms to the floor. If you can do that without bending your knees, you get 1 point for palms to the floor. Then there's 1 point each for putting your thumb to your forearm. So right and left, there you can get a total of 2 points for that. And then also the measurement of how far back does the pinky go from the fourth finger. And we're measuring the angle at the metacarpal phalangeal joint. So we want to know, does that go beyond 90 degrees? And then for the elbows and the knees, for both of them, we're looking to see whether there's hyperextensibility beyond 190 degrees in each of those joints. So you can get 2 points for the elbows and 2 points for the knees. And together, that's a total of 9 points. So for the classical type of Ehlers-Danlos syndrome, in the 2017 criteria, the clinical diagnosis is made, you have to have that skin hyperextensibility and atrophic scarring, and then either the major criteria of joint hypermobility or 3 of 8 different minor criteria. And those minor criteria are listed in that paper that's describing the classical type. The committee considering classical Ehlers-Danlos syndrome felt very strongly that we should try to verify the clinical diagnosis whenever possible. Molecular analysis of the genes encoding type 5 collagen identifies a causal mutation in more than 90% of patients with classical EDS, and it should be used as the standard confirmatory test. Now, for vascular Ehlers-Danlos syndrome, there are a large number of major and minor criteria, and those are listed on this slide. The major criteria are the family history of vascular EDS with a documented known variant in COL3A1. This is the gene that encodes type 3 collagen, which is the protein that is altered in the vascular type. Another major criteria is arterial rupture at a young age, generally considered to be less than 40. Spontaneous rupture of the sigmoid colon in the absence of known diverticular disease or other pathology that might explain such a rupture. And then also women with the vascular type of EDS are at risk of uterine rupture during the 3rd trimester. And so if a person has had a uterine rupture in the absence of a previous C-section, we consider that to be a major criteria. And then there's also another vascular anomaly called the carotid cavernous sinus fistula that may form, and if that's seen in the absence of trauma, that's a big red flag to consider the diagnosis of vascular EDS. Then we have this long list of minor criteria, and I'm not going to go through all of them because really the major thing to think about is in terms of what should prompt us to think about the vascular type of EDS. There are 4 main criteria: the family history of the disorder, arterial rupture or dissection at less than 40 years, the unexplained sigmoid colon, and spontaneous pneumothorax. So in the presence of other features that are consistent with the vascular type of EDS, any one of these criteria should make people think about the possible diagnosis of vascular EDS. And really, the diagnosis of vascular EDS hinges on that molecular test with the identification of a causative variant in 1 copy of the type 3 collagen gene in a person's DNA. Now, the hypermobile type of Ehlers-Danlos syndrome is really, it's the most common of the types of Ehlers-Danlos syndrome. And it's the one where the most changes were made in terms of thinking about the diagnostic criteria. So based on these 2017 diagnostic criteria, we're really, we need 3 different areas to be met in order to make the diagnosis of hypermobile Ehlers-Danlos syndrome. And they include generalized joint hypermobility, systemic evidence of a more general hereditary disorder of connective tissue, and the absence of features that suggest other diagnoses. And so to meet the hypermobile criteria number 1 of generalized joint hypermobility, that Beighton score that I was talking about earlier, we now have a graded cutoff depending on people's age. So for children and adolescents, less than or equal to 6 is the requirement for a positive Beighton score. For men and women who are after puberty and up to age 50, greater than or equal to 5 would be considered positive, and for men and women over 50, greater than or equal to 4. And the committee also felt that if people were 1 point shy of meeting the diagnosis of generalized joint hypermobility based on the Beighton criteria, we can also use this 5-point questionnaire, which assesses for a sort of historical evidence of hypermobility. Excuse me. And if a person has 2 positive answers on this 5-point questionnaire and a Beighton score that's 1 point less than the cutoff, we can still say they have generalized joint hypermobility for this diagnosis. Now, criterion 2, this is evidence of a more generalized hereditary disorder of connective tissue, and we have 3 possible features within criteria 2. So we need to fulfill 2 of those 3 features. So it can be A, B, B and C, or A and C. And A is the systemic manifestations, and there's a long list of which we need 5 in order to say it's positive. B is the positive family history, and C is evidence of musculoskeletal complications. So fortunately, all of these features are on your slides, on your flash drive, and also available in the manuscript. So I'm not going to go through all of them in detail, but we need 5 of this list on this page and the next one in order to say that feature A of this criterion 2 is met. Feature B is the positive family history, and it's important to note that we have to say that there's a first-degree relative who independently meets the diagnostic criteria, these new diagnostic criteria, in order to say that there is a positive family history. And then feature C is the musculoskeletal complications, at least one of these 3 things. So musculoskeletal pain in 2 or more limbs, recurring daily for at least 3 months, chronic widespread pain for more than 3 months, and then recurrent joint dislocations or frank joint instability in the absence of trauma. And lastly, criterion 3, basically we're saying we have to make sure that it's not something else. Like, so if a person has generalized joint hypermobility and evidence of a generalized hereditary connective tissue disorder, is there anything suggestive of another hereditary connective tissue disorder? Are we sure that we've really considered what we call the differential diagnosis and excluded all the other possible explanations for the clinical observations and the problems the patient is experiencing? Now, there was a general recognition that there are going to be a lot of people who have generalized joint hypermobility but do not meet these new diagnostic criteria for the hypermobile type of Ehlers-Danlos syndrome. And Dr. Marco Castori from Italy came up with the idea of thinking about a spectrum of joint hypermobility. And these are the hypermobility spectrum disorders. So you can see here, we may have generalized joint hypermobility. Is this? I don't know. If you look along the column on the left-hand side, you have GJH, which is generalized joint hypermobility, PJH, peripheral joint hypermobility, which means the hypermobility is pretty much limited to the small joints in the hands and the feet. Or you might have limited joint hypermobility, where the joint hypermobility is limited to single joints or body parts. So those can be asymptomatic, or they may be symptomatic, generalized hypermobility spectrum disorder, peripheral hypermobility spectrum disorder, or limited hypermobility spectrum disorder. Or you might have hypermobility spectrum disorder based on the history. In other words, the person in front of you in the examining room may not have hypermobility right now, but maybe they were extremely hypermobile as a younger person. So that would be the historical presence of joint hypermobility. And then at the extreme end of the spectrum, we have hypermobile Ehlers-Danlos syndrome that meets all the criteria that I was discussing before. So we see autonomic dysfunction in many different types of Ehlers-Danlos syndrome. We see cardiovascular manifestations of autonomic dysfunction, gastrointestinal, genitourinary, and neurologic features. And there is a long list of potential causes of dysautonomia in EDS, just like there's a long list of potential causes of dysautonomia in people who do not have EDS. And this list completely overlaps the list in the non-EDS population, with the possible exception of the brainstem impingement from Chiari malformation or craniocervical instability, which we may see more frequently in people with Ehlers-Danlos syndrome. And I guess I would say the venous pooling and venous dilation is probably more common in the EDS population as well. So in the interest of time, I'm going to just scoot along here and say that the take-home message really is that physicians treating patients with dysautonomia may be the first to think of Ehlers-Danlos syndrome, and you as patients with dysautonomia should have it on your radar screen as a possible comorbidity to the dysautonomia. So we're really encouraging people, physicians, to think about joint hypermobility in every patient who presents with dysautonomia. Heidi Collins, who was the chairman of the Medical Advisory Board, recognizing the many comorbidities that we see in Ehlers-Danlos syndrome, suggested when you can't connect the issues, think connective tissues. And my thanks to all the patient support groups and Shane Robinson, Laura Bloom, Peter Rowe, Alan Posinki, and all my patients and their families. And thank you very much for your attention.